Hello, everybody. This is May Pian Smith from the editorial board of OpenAnesthesia.org and A&A. And today I have the pleasure of having an interview with Dr. Alok Agarwala, who is the lead author of the June 2017 Article of the Month. The article's entitled Measuring and Improving the Quality of Pre-Procedural Assessments. Dr. Agarwala is faculty at Harvard Medical School, and he's division chief for general surgery anesthesia and associate director of quality and safety for the Department of Anesthesia at Mass General Hospital. Thanks for being with us, Alok.
Thank you for inviting me to do this. It's my pleasure.
So not everyone will have had an opportunity to read your article before they hear this webcast. And so I wonder if you can give a brief overview of your study, for example, why and how you conducted it, and what you think the important conclusions are.
Sure. So at our institution, there felt like there had been this general feeling that the preoperative evaluations, the pre-procedure evaluations, were very inconsistent in their quality. And for years, we had been hearing complaints about the process in which patients were evaluated preoperatively and the information that was available to clinicians on the day of surgery. So using a previously described tool that primarily was used to collect information about adverse events at the end of each case, a self-reporting tool that was part of our electronic medical record, we thought that we might be able to modify that tool in a way that allowed us to collect information in somewhat real time for quality improvement purposes, in addition to the self-reporting of adverse events. So we took this tool that every provider was required to complete at the end of a case before closing the case in the electronic medical record, and added a question about the quality of the preoperative evaluation for that anesthetic that they had just completed. And so by asking this one question and giving some choices about the quality and leaving space for free text comments, we hoped we could gather feedback about the true quality of the evaluations and look for areas in which we could improve. We evaluated more than 37,000 cases, of which 17,000 had these voluntary ratings of the preoperative evaluation. We went a bit further and performed chart reviews and a qualitative analysis on a small subset that had free text comments, specifically what we called constructive free text comments, areas where we thought there was a comment that we could find some area for improvement. And in addition, to be able to better assess the correlation between provider satisfaction, sort of people's opinions about these things, with the real-time data that we were collecting at the end of each case, we also performed a survey at the midpoint of the project, just a provider satisfaction survey to gauge how providers felt, at least subjectively, about the pre-procedure evaluations as we were in the midst of evaluating them. The conclusions that I think were most salient from our work, the first is really that the overall rate of unsatisfactory evaluations was very, very low. So out of the 17,000 plus that we looked at, 1.4% were rated as unsatisfactory, which means that 98.6% were actually rated as satisfactory or exemplary. Most commonly, when evaluations were rated as unsatisfactory, the most common reasons identified were that specific pieces of information were missing or the assessments were thought to be inadequate. The second point that I think was interesting is that inpatient evaluations were actually most likely to be rated exemplary when compared to clinic visits that were done prior to the day of surgery or phone-based evaluations that were done prior to the day of surgery. But nevertheless, the difference between phone screens and those patients that were evaluated in the clinic was really very, very small. And I think that's important because the phone screens are a more cost-effective model of providing pre-procedure evaluation using registered nurses that are supervised by MDs as compared to the clinic model, which utilizes anesthesia residents, nurse practitioners, and attending anesthesiologists to do the clinic visits. And what we found is that even between those two types of visits, while there was a small difference, the difference is really very, very small. And I think one of the most important conclusions was that providers' perceptions varied quite significantly from the data we collected in real time. When individual anesthetists rated the quality of the evaluation at the end of the case, they rated them as unsatisfactory only 1.4% of the time. Yet when we surveyed clinicians in the department, they thought, when asked specifically how frequently within the last month they'd had an unsatisfactory preoperative evaluation, they rated on the survey that being more than 11% of the time. So a big difference between 11+% and 1.5% being thought of as unsatisfactory.
Great, thanks. So there are a lot of great points that you made, and we can probably go in order a little bit. Initially, you talked about how you were concerned about in the paper that unsatisfactory pre-ops might lead to delays or decreased efficiency. And I wonder if you also have a sense of how they might have contributed to actual case cancellations. It occurred to me that if you're collecting data real time at the end of case, could you capture contributing factors for a case that didn't actually happen on an originally scheduled day?
So unfortunately, our study didn't look specifically at case cancellations. Our case cancellation rate at our institution is quite low at baseline, but the design of the study did not specifically focus on case cancellations, and so we couldn't really say, as you point out, what factors existed when cases were canceled. If a case was canceled on the day of surgery, we did not collect information on the quality of that evaluation specifically, and we didn't really go back in to look at case cancellations to see what factors led to those case cancellations.
Okay, so it was a good conclusion from your study that actually the telephone calls screenings from nurses were quite effective. But you did mention that in-house pre-ops were overall thought to be of better quality than those performed in other settings. And I wonder if you can identify reasons that may have been the case. Or are there aspects of the in-house evaluation that could be incorporated into the other types of pre-op assessments?
So yes, the inpatient evaluations did have a higher rate of being rated as exemplary than those that were done by the phone screen or the clinic. One of the primary reasons that we think that was the case is that the in-house evaluations were most frequently done by anesthesia providers themselves as compared to RNs or nurse practitioners. Often also in-house evaluations were done by practitioners that were actually going to be taking care of the patients the next day. We didn't quantify, we don't know how often that was the case compared to one of the colleagues having done that preoperative evaluation for the inpatients, but at least we know from our practice that some of the time we would have residents, for example, see their own patients for the next day. And then if they're evaluating their preoperative evaluation, they had done it themselves perhaps for some of the time. But more specifically, I think one of the things that we could do, and one of the things that we did do, is our inpatient evaluation actually had a more complete and thorough template, a structured preoperative evaluation template that was used for the inpatient pre-op evaluations that wasn't necessarily being used consistently for those evaluations that were being done over the phone or in the paid clinic. And so I think one of the things that was most beneficial is that we did take that inpatient evaluation and modify it, but implement a structured, more comprehensive template for all providers to be using for preoperative evaluations happening prior to the day of surgery.
I was also interested to see, as you mentioned, that in your midpoint survey, clinicians had the impression that overall pre-op quality was lower than what was suggested when they gave daily feedback after individual cases. So I wonder if you can talk about your ideas of how cognitive psychology contributes to that impression.
So there's been studies that have shown this, and what's interesting is that negative impressions far outweigh neutral impressions in our memory. And we think that when patients have had inadequate assessments or incomplete evaluations, or things were missing or they were inadequately worked up, that the impression that that leaves on one's memory far outweighs all of the many cases where the evaluations were good. And I think there's something about our psychology that just sort of remembers the negative more than the neutral. Certainly we remember some positive things really well as well, but I think that's the best explanation that we have for that sort of physician satisfaction or provider satisfaction with the real-time ratings.
Yeah, and I guess we can all think of examples where that happens in all aspects of our lives, really. So many readers and listeners will be studying your work and trying to extrapolate about how to make improvements in their own settings, and certainly we all practice in very different types of settings. Can you share ways in which you've improved your own pre-op assessment process as a result of this study? And can you identify a few key ingredients for process improvement that you think are important for success?
Sure. I think I mentioned the first thing that I think can be done, or one of the things that we did here, was to really work on creating a standardized template for all pre-procedure evaluations. And in order to do that, we started with what I guess you would call expert opinion with a small group of folks who created the first pass, but then we really sent it back and forth with a large number of frontline clinicians to try to refine the tool that was going to be used as the standardized template. The second thing that we did was really to focus on a more robust education and training process for the RNs and the NPs and the residents that were rotating through the preoperative clinic, so that everyone started with a better baseline for what was expected in the preoperative evaluation, what was necessary for preoperative cardiac testing for non-cardiac surgery, and the guidelines and the things that are out there that we should be following. And I think that has helped as well. We've always had, but sort of really focused on the fact that we have a small number of dedicated staff whose primary role in our department is to be in the pre-assessment clinic. And they've really driven the education and the training and created the standards for everyone else who spends some time, but not all of their time, in the pre-assessment clinic. As far as process improvement tools that I think are important for success, the engagement of frontline clinicians is critical. You really want to include the folks that are really going to be caring for the patients on a day-to-day basis, and especially the really complex patients, to find out what it is that they want and in what format do they want to see the information that makes it easy to digest and to prevent missing critical pieces of information. The other thing that we were able to do, and I think is critical, is that we were able to provide specific feedback to the staff that were doing the pre-assessment evaluations. The nurses and the NPs, we had specific pieces of information that came out of our study that we were able to feed back to them for things to focus on. So one example would be laboratory evaluation. So one of the complaints was that patients would come for the day of surgery without having appropriate blood bank testing. And when we looked back, there were specific cases and specific reasons why that didn't occur, but rather than giving the feedback of saying, oh, well, just make sure everybody gets the appropriate labs done, we were able to say blood bank specimens were really critical in the experience of the patient and the providers on the day of surgery. And so we were able to make sure that the really critical things were specifically focused on, rather than just giving blanket statements that were less likely to result in improvement.
Well, great. Thank you, Dr. Agarwal. I really want to thank you for your study, which addresses a challenge that all of us anesthesia providers face, no matter what our specialty is. And it's always great for me to hear directly from the authors, and I know that it means a lot to our listeners to hear from you as well. So thank you.
Thank you. Thank you for the opportunity to discuss our study.